Hello students, welcome to this session. So today we are going to discuss about anemia, very common condition in all the population. So we will see what is the definition, different types and then clinical features and which investigations are required for the diagnosis of the anemia.
Now let's see one case. A 46 years old female working as a sales representative at esteemed company came to OPD with complaints of breathlessness while climbing steps, while walking fast, and palpitation and headache. She also gave history of irregular menstrual cycles with increased bleeding and for longer duration. No history of any addictions. On examination, thin build, afebrile, pulse 88 beats per minute, respiratory rate 18 per minute, blood pressure 110 by 70 millimeter of mercury. Pallor noted +3 grade on palpebral conjunctiva, tongue and nails. Cardiovascular system, respiratory system and per abdomen within normal limits. So looking at the history and examination findings, investigations advised CBC, complete blood cell count, ESR, PBS to know the morphology of the RBCs and other findings. Urine routine, stool routine, iron profile, vitamin B12 study and serum folic acid. The findings of the investigations: CBC hemoglobin 7.8 gram %, that means it is decreased. MCV, MCH and MCHC all are decreased, and RDW red cell diameter width increased. ESR 45 millimeter, that means it is increased, and in peripheral blood smear RBC morphology, microcytosis, hypochromia, anisocytosis, that means variation in size of the RBCs, then poikilocytosis, variation in shape of the RBCs. So RBCs, few are like pencil shape, teardrop shape, elongated, oval. Then in urine routine, it is within normal limits, and stool routine, no parasites in. So based on these routine findings, what is your diagnosis? So it is anemia. Now patient is having anemia, but which type of anemia? Because according to that we have to give treatment to the patient. So special investigations are done like iron profile. So in that serum iron was decreased, total iron binding capacity increased and percentage saturation decreased. Vitamin B12 and folic acid normal. So now our diagnosis is iron deficiency anemia, and now we can treat patient according to the iron deficiency anemia. Now let's study some basics of the anemia. So definition: when the hemoglobin value is low as the extreme normal range of the age and sex of individual, it is called anemia. So clinically patient presents with fatigue, weakness, tiredness, effort intolerance, effort breathlessness, that is dyspnea, faintness, sometimes patient falls, bleeding conditions, headache, palpitation, poor concentration in study or work. So now how to classify anemia? So there are two types of classifications: morphological classification and etiological classification. So first we will see etiological classification, that is based on the reasons. So first reason, it can be blood loss. So it can be acute or chronic. So if acute blood loss, it can be seen in accident when the blood loss is there, or injury, operation. Then chronic blood loss, so it can be seen in hookworm infection, menstrual bleeding excessively, then bleeding from gums, nose, piles, fissure. So they are in small quantity, but because of the chronic loss you can see anemia, that is decreased hemoglobin concentration. Second reason can be impaired red cell production. So because of the deficiency of the things which are required for formation of hemoglobin, like iron, vitamin B12, folic acid, proteins, so because of deficiency of this, the red cell production is less and then hemoglobin value is less. Then third reason can be the excessive red cell destruction or lysis, that is seen in hemolytic anemia. And the hemolytic anemia, the red cell destruction can be intracorpuscular or extracorpuscular. So that we will see in detail when we will see hemolytic anemia. The second type of classification is morphological classification. So it is based on findings of MCV, MCH, MCHC and RBC morphology in peripheral blood smear. So first type is normocytic normochromic anemia. So in that MCV, MCH, MCHC all are normal. Then second type is microcytic hypochromic anemia. So in that MCV, MCH, MCHC all are decreased, and in PBS we can see smaller size of the RBCs, that is microcytosis, and less concentration of hemoglobin, that means less quantity of red cells, that is redness to the red cells, so it is called hypochromia. And the causes for this condition can be iron deficiency anemia, sickle cell anemia, thalassemia. The third type is macrocytic anemia, when the MCV is more than 96 femtometer and the RBC morphology, they are increase in size in the peripheral blood smear. And the conditions are megaloblastic anemia, pernicious anemia, hemolytic anemia also one condition. So investigations done are two types: routine investigations to know whether anemia is there or not there, and specialized investigations to know which type of anemia. So first, routine investigations. So basic investigations like blood routine, that is HB, CBC, ESR, PCV, peripheral blood smear for RBC morphology and typing of anemia, red cell indices, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, red cell diameter width, so that you can see in cell counter readings, urine routine for urobilinogen to know hemolytic condition, stool routine, that is parasites can be seen in stool microscopic examination, example hookworm, which causes iron deficiency anemia. Then specialized investigations for typing of anemia. So iron profile for the iron deficiency anemia, thalassemia, hemoglobin electrophoresis, osmotic fragility test, fetal hemoglobin test. For sickle cell anemia, sickling test, hemoglobin electrophoresis. Then for megaloblastic anemia, vitamin B12 and serum folic acid estimation. For pernicious anemia, vitamin B12, folic acid and intrinsic factor investigation. Hemolytic anemia, retic count in peripheral blood smear, normoblast can be seen, and osmotic fragility test. Aplastic anemia, bone marrow examination to rule out aplasia, that is pancytopenia. So these are all specialized investigations for typing of anemia so that we can give specific treatment to the patient. Let's see first type of the morphological classification, microcytic hypochromic anemia. So it is decrease RBC size, decrease MCV less than 80 femtometer in size, then decrease MCV, decrease hemoglobin, decrease MCH and MCHC, that is hypochromia, and increase pallor of the RBCs in peripheral blood smear is called as microcytic hypochromic anemia. So RBC size is decreased and hemoglobin is decreased. The causes for this is very common cause is iron deficiency anemia. Then can be genetic defect seen in few children, that is thalassemia, and sometimes anemia of chronic disease like tuberculosis, rheumatoid arthritis. Then in blood picture we can see decreased hemoglobin, decrease or RBC indices like MCV, MCH, MCSC, and in PBS we can see microcytosis and hypochromia. Special investigations done for confirmation. So for iron deficiency anemia we can do iron study, in that serum iron, serum ferritin, percentage saturation and TIBC can be done. And thalassemia we can do osmotic fragility, fetal hemoglobin and confirmatory test, that is hemoglobin electrophoresis. Iron deficiency anemia, the most common type of anemia, it occurs at all ages, especially in females and children. Iron deficiency anemia develop when supply of iron is not sufficient for hemoglobin synthesis, because for hemoglobin iron is required. So causes can be in females, the monthly regular blood loss, that is menstruation, pregnancy, and decreased iron intake in diet, because previously females used to eat after everyone is eaten, so they used to get decreased diet. And in children, decreased iron intake because children are little very choosy, and blood loss can be there because of the parasites like hookworm. Routine investigations like CBC, ESR, PCV, peripheral blood smear can be done, and then special investigations like iron studies for confirmation of iron deficiency anemia, that is serum iron, which is decreased in IDA, then ferritin decreased, TIBC, total iron binding capacity increase in iron deficiency anemia, and percentage saturation is decreased. Peripheral blood smear examination can be done for iron deficiency anemia. So in that we can see blood picture like microcytosis, RBC size decreased, hypochromia, that is pallor of the RBC increased, anisocytosis, that is different size of RBC, few RBCs are smaller in size, middle size, bigger in size. Then poikilocytosis, different shapes of RBCs you can see in this diagram. Few RBCs are elliptical, teardrop, pencil shape. Then occasional normoblast, occasional target cell can be seen, and retic count is slightly raised. So this is blood picture for iron deficiency anemia. Prevention is always better than the treatment. So we can prevent anemia, and the iron deficiency anemia is very common in Indian setup, so we can prevent that by taking diet iron rich food, that is jaggery, green leafy vegetables, dates. Then treatment of acute and chronic blood loss should be done, early medical checkup by doctors, then investigations for diagnosis and typing of anemia should be done, early treatment for prevention of complications of the anemia should be there.
Macrocytic anemia, when the RBC size is increased or MCV is increased, it is more than 100 femtometer. Causes can be megaloblastic anemia, hemolytic anemia, or sometimes it can be aplastic anemia. So in blood picture, in peripheral blood smear, we can see increased RBC size, that is macrocytosis. Then special investigations we can do according to the cause, like megaloblastic anemia we can do vitamin B12 or folic acid estimation. For hemolytic anemia we can do retic count or osmotic fragility test. Megaloblastic anemia, so when macrocytic anemia is because of the vitamin B12 or folic acid or both deficiency, it is called as megaloblastic anemia. The name megaloblastic means mega means more or increased size of the RBC. So etiology can be because of the decreased intake of vitamin B12 or folic acid, like decreased intake of leafy vegetables, or intake is normal but the decreased absorption because of the gastric causes like gastric atrophy, pernicious anemia, or intestinal causes like disease of small intestine like celiac disease or ileitis. So in blood picture in PBS you can see macrocytosis. So in this diagram you can see increased RBC size, the macrocytosis, and because of that there is variation in size, so it is also called as anisocytosis. Then the neutrophil is usually hyper segmented, more than 4 to 5 lobes of the neutrophils, the nucleus, and in MCV of the RBCs increase. Special investigation can be vitamin B12 serum or serum folic acid can be done, or bone marrow examination. In that you can see increased cellularity because of the increased RBC production, and then many megaloblast you can see with Howell-Jolly bodies. So Howell-Jolly body is pink color dot present in the megaloblast in the bone marrow or in the macrocyte in PBS. So it is called Howell-Jolly bodies. It is diagnostic of the megaloblastic anemia. Pernicious anemia, so it is anemia because of the deficiency of vitamin B12. So intake of the vitamin B12 is normal but absorption is less because of the gastric atrophy or gastritis, which results in the macrocytic anemia, that is increased RBC size, and then glossitis, that is infection of the tongue, and nervous development. So it is because of the deficiency of intrinsic factor. So this intrinsic factor is secreted by the stomach cells, and because of the gastritis there will be deficiency of intrinsic factor, and then or maybe antibodies present in gastric juice against the intrinsic factor, and so it decrease vitamin B12 level, and then it causes megaloblastic anemia. So it is megaloblastic anemia due to deficiency of the intrinsic factor which is secreted by the gastric cells. So in blood picture it is similar to megaloblastic anemia, that is macrocytosis, anisocytosis, and in serum vitamin B12 is decreased, and but folic acid may be normal. And when you do serum intrinsic factor, it is decreased, or serum intrinsic factor antibody test is positive. Hemolytic anemia, so it is because of the red cell destruction is increased, that is hemolysis. So this can be because of the intracorpuscular mechanism, that is it is present inside the RBC, like membrane defect you can see in sickle cell anemia, thalassemia, or abnormal hemoglobin can be seen in sickle cell anemia or thalassemia. Then it can be because of the extracorpuscular or extrinsic mechanism, so in that it is drug induced, or it is because of the burns, chemicals, or poisoning like lead poisoning, or it can be seen in newborn because of the Rh incompatibility. So investigations, hemoglobin is decreased, hemoglobin is present in urine, and then we can do antibody test in hemolytic disease of newborn. Sickle cell anemia, as the name suggests, the RBC become sickle in shape or half moon shape because of the abnormal hemoglobin, that is HbS, and in that there is substitution of valine for glutamic acid in 6th position of the beta chain of the hemoglobin. So this is a hereditary disorder, and it is because of the decreased oxygen tension is there because of the abnormal hemoglobin S, and because of that the RBCs become rigid and sickle shape when there is deficiency of oxygen, like at the high altitude, and then RBCs are fragile and they cause hemolysis. The symptoms, the face of the person is changed, it is usually childhood disease, and in that we can see abdominal joint or bone pain, and spleen is enlarged because of the increased hemolysis. So in blood picture you can see sickle shape RBC, sickling test is positive, hemoglobin solubility test is positive, and the confirmatory test for sickle cell anemia is hemoglobin electrophoresis. Thalassemia, it is group of disorders which genetically determine reduction in rate of synthesis of one or more type of normal hemoglobin polypeptide chain, so either alpha or beta chain. So the two types of thalassemia: alpha thalassemia when there is reduced alpha the type of polypeptide chain, and beta thalassemia when there is reduced beta polypeptide chain. So etiology, it is genetic or hereditary disorder, and in blood picture you can see hemoglobin is very much decreased, less than 6 to 8 gram per deciliter. Then there is microcytosis, that is RBC size is decreased, hypochromia, RBCs are pale, that is hemoglobin concentration is decreased in RBC, and because of the size variation you can see anisocytosis, shape variation you can see poikilocytosis, and there is typically increased target cells. So target cells, they have double red color, so one in the center and one at the periphery, and sometimes basophilic stifling, that is purple color granules can be seen inside the RBCs. Then retic count is increased, and there is the microcytic hypochromic anemia. So all RBC indices like MCV, MCH, MCSC all are decreased, and osmotic fragility test is increased concentration. Special investigations we can do bone marrow examination and hemoglobin electrophoresis for the confirmation of the thalassemia. Aplastic anemia, as the name suggests, there is aplasia, that is all the cells are decreased, and etiology can be because of the long exposure to the chemicals, drugs, x-ray, infection, or overuse of antibiotics, chemotherapy, radiotherapy. So in that there is pancytopenia, that is anemia. In that you can see breathlessness, leukopenia, so more prone to infection, thrombocytopenia, more prone for the bleeding. So investigation, hemoglobin, CBC, ESR increase, then CBC you can see WBC decreased, and in differential count there is different cells, then platelet count decreased. In PBS there is microcytic hypochromic anemia with leukopenia and thrombocytopenia. So picture of pancytopenia, that is all cells are decreased. So confirmatory test for this is bone marrow aspiration. So in that cellularity is decreased, erythropoiesis, myelopoiesis, and thrombopoiesis shows megakaryocytes increase, and then bone marrow biopsy can be done for the confirmation after bone marrow aspiration.
So in that, fatty area is increased and cells are decreased. Hello students, welcome to this session. Today we will have lecture on leukemia. So what is the definition, classification, the clinical features, that means symptoms of the patients, and then how to lab diagnose the leukemia. Now let's see one case why CBC parameters are so important. So a young boy, he's B chemical, he came to Bombay for job. So in that, medical examination done and CBC advised. So he came to Nanavati hospital lab and then CBC is done. So in that, the first CBC count, that is the total WBC count, was 74,000 cells per cubic millimeter. Then peripheral blood smear report done, and in that many blast cells seen. So bone marrow aspiration and bone marrow biopsy advised, and it is done. And the person diagnosed as AML, that is acute myeloid leukemia. Then few cycles of chemotherapy given. Then because he was very young, so bone marrow transplantation advised. So he has six brothers. So one brother's bone marrow matched and then transplantation done at Tata Hospital. After few months, he came to Nanavati Hospital again for the CBC investigation, and that time it was a normal report. So because of the CBC, the person got diagnosed AML earlier, and then he got treatment earlier and then early cure. That is why CBC is very important. So in CBC, what are the CBC parameters? So it is hemoglobin, total RBC count, total platelet count, total WBC count, then differential leukocyte counts. In that we can see agranulocytes like lymphocytes, monocytes, and granulocytes like neutrophil, eosinophil, and basophil. And RBC indices, in that PCV, MCV, MCH, MCHC, and RDW can be seen. So all these parameters we can do manually, but because of the calculations it takes longer time. So nowadays, because of the advanced automated cell counter system, we can do all these parameters within a minute in one aspiration in the cell counter. So definition of leukemia. So this is abnormal proliferation of the hemopoietic cells, that is abnormally hemopoietic cells, that is precursors of the RBCs, WBCs, and platelets, that is the immature forms of all these blood cells. They are abnormally increased, and then because of that they infiltrate into the bone marrow, and then the process of differentiation in leukemic cells is often abnormal and is commonly result in immature morphological appearance. So they are also called as blast and the other forms of the immature cells. So that abnormal proliferation of the hemopoietic cells is called as leukemia. Now we will see etiology. So what is the reason for that? So it can be seen because of the alteration of structure of DNA in the nucleus, and then chromosomal abnormalities like very common in leukemia, and then because of the radiation or chemicals like benzene, so people working in benzene factory, or few viruses which are causing this leukemia, and then some genetic factors are there. So these are all the etiological factors which are responsible for the leukemia. Now we will see classification of leukemia. So they are classified as acute and chronic according to the clinical symptoms of acute onset or chronic disease. And then they are divided into myeloid and lymphoid type according to the cell line, that is morphology of the cell line involved in the leukemic process. So leukemia is classified as acute when more than 30% of the bone marrow consists of blast cells. And then it is divided into acute myeloid leukemia or acute lymphoblastic leukemia according to the series of the myeloid or lymphoid series involved. Then chronic, when the less than 30% of the bone marrow consists of blast cells, it is called as chronic leukemia, and again it is divided into chronic myeloid leukemia or chronic lymphoblastic leukemia according to the series of the cells involved. So now acute leukemia is divided into two types, acute myeloid leukemia and acute lymphoblastic leukemia. So now acute myeloid leukemia is divided into 7 types. So they are labeled as M1, M2, M3, M4, M5, M6, M7. So M1 is myeloblastic leukemia without maturation. M2 is myeloblastic leukemia with maturation. So nucleus is matured in the M2 type. Then M3, hypergranular promyeloblastic leukemia. M4 is myelomonocytic leukemia. M5 is monocytic leukemia, then M6 is erythroleukemia, M7 is megakaryocytic leukemia. Then acute lymphoblastic leukemia are of three types: L1, L2, L3. So L1 is small lymphoblast, they are homogeneous, so all are the mostly small lymphoblast. L3 is large homogeneous lymphoblast, and L2 is mixture of, that is heterogeneous, so it consists of small plus large lymphoblast. Now chronic leukemia, so it is chronic myeloid leukemia or chronic lymphoblastic or lymphocytic leukemia. So clinically patient is presenting with acute leukemia. So most common symptoms are anemia, fever, malaise, bleeding, that is hemorrhage, bruising, pateki. So bleeding can be from the gum or from the nose or from the skin. Then less common symptoms are infection of the mouth, pharynx, pain in bone and joints, mainly in childhood, upper respiratory tract infection, mainly in childhood. Now we will see lab diagnosis of leukemia. So investigations can be done. So routine investigation like hemoglobin, CBC, ESR, PBS and platelet count. So in PBS then we can see morphology of the cells. So it is RBC, microcytic anisocytosis, that is variation in size of the cells, poikilocytosis, that is variation in shape of the RBCs, then normoblast, that is nucleated RBC, that is immature form of the RBC is seen, polychromasia, that is purple RBCs, then increased retic count is there. WBC total count is markedly increased up to 1 to 4 lakhs the cells per cubic millimeter can be there. In differential count, major cells are blast cells, so more than 30%, or mainly cells are blast cells, either myeloblast or lymphoblast according to the acute myeloid or acute lymphoid series. Then platelets are increased, so it is hypercellular response. Then we can do bone marrow for the confirmation. So bone marrow is hypercellular, so all the many cells are there, and then the fatty area is less. Then in acute leukemia more than 30% myeloblast cells are there. In chronic leukemia less than 30% blast cells are there. In chronic myeloid leukemia cells of myelocyte series are increased, and basophilia is also there. These are my references from where I have taken my notes, and I hope you find this session very useful for your academics and for your future practice. Thank you so much. Hello students, welcome to this session. So today we are going to study about other hematology blood disorders. So other than anemia, leukemia, so blood disorders are polycythemia, spherocytosis, multiple myeloma, systemic lupus erythematosus, lymphoma, etc. First is polycythemia. So it is disease state in which hematocrit, volume of RBCs in blood is increased, or hemoglobin concentration is increased in the blood. Symptoms are high blood pressure, formation of blood clots, can be headache, vertigo, dizziness, fatigue, tiredness, lack of concentration. Unusual bleeding, nose bleeding, itchiness after exposure to warm water due to histamine and prostaglandin release, numbness, tinglings in body parts, burning pain in hands, feet, reddish bluish discoloration of skin, also called as erythromelalgia. Complications can be because of the blood clots, thrombosis, heart attack, stroke, deep vein thrombosis, Budd-Chiari syndrome, hepatic vein thrombosis, pulmonary embolism. On examination, on physical examination, patient is plethoric, that is red in color, per abdomen, spleen and liver enlarged. Investigations: RBC 8 to 9 million cells per cubic millimeter. WBC and platelets are also increased, ESR decreased, PCV is increased more than 55%. So 70 to 80% is also there. So there are two types: absolute or primary polycythemia vera and relative polycythemia vera. So first, primary can be because of the increase in RBC. So it can be because of overproduction of RBC due to primary process in bone marrow. Myeloproliferative syndrome, chronic disease, low oxygen levels, malignancy, over transfusion of RBCs. Relative can be decrease in plasma volume, so decreased water loss in dehydration, burns, stress. Secondary polycythemia due to natural or artificial increase in erythropoietin, also called as physiological polycythemia. Conditions: altitude related, hypoxia, cyanotic heart disease, sleep apnea, smoking, carbon monoxide poisoning. Iatrogenic causes can be phlebotomy, bloodletting, and concentrated blood RBC transfusion. Investigations: RBC 8 to 9 million cells per cubic millimeter, WBC RBC increased, and ESR decreased, PCV increased, serum erythropoietin low. Treatment: phlebotomy, removal of blood from circulation, that is called bloodletting. Drugs can be aspirin, myelosuppressive drugs like hydroxyurea, and oxygen therapy. Spherocytosis, it is a hereditary disorder, that is because of the problems with RBCs. Instead of biconcave disc, RBCs are round like spears, are called spherocytes, and are more fragile than the normal RBCs. Causes: warm autoimmune hemolytic anemia, cold autoimmune hemolytic anemia, paroxysmal cold hemoglobinuria, hemolytic blood transfusion reaction, hemolytic disease of newborn, snake bite, hyposplenism. Pathology: molecular defect in one or more of protein of RBC membrane, so RBC contracts to spear. RBC has high osmotic fragility when placed into water. RBCs are more likely to burst than normal RBC. Symptoms: patient is having anemia, jaundice, enlarged spleen. Blood picture: in PBS, spherical RBCs are many, reticulocyte count is increased, osmotic fragility test, it is increased, serum bilirubin is increased. Multiple myeloma, it is cancer of plasma cells, that is one type of WBC that normally produces antibodies. So risk factors can be obesity, radiation exposure, family history, chemicals, Epstein-Barr virus. Pathology: plasma blast proliferation leads to increased plasma cells, leads to abnormal antibodies deposited in various organs. Signs and symptoms: bone pain, fatigue. Complications can be amyloidosis, kidney disease, bone fracture, infection, anemia, hyperviscosity syndrome, bone lesions, osteoporosis. Investigation: blood, anemia, hemoglobin less than 10 gram percent, PBS, rouleau formation of RBC seen, increased calcium more than 11 gram percent, increased serum creatinine, urine, Baines-Jones proteins are present, protein electrophoresis of blood and urine, paraprotein, that is M protein band present, quantitative measurement of immunoglobulin A, IgG and IgM increase, beta 2 macroglobulin present, bone marrow biopsy, increased plasma cells more than 10% in the bone marrow, myeloma cells, single nucleus with single nucleolus with vesicular nuclear chromatin and is eccentric and with abundant blue cytoplasm that you can see in this picture. Systemic lupus erythematosus. So it is autoimmune disease in which body's immune system mistakenly attacks healthy tissue in many parts of body. Causes can be genetic, hormonal like estrogen, environmental like female sex hormone, then sunlight, smoking, vitamin D deficiency, infections. In SLE, body's immune system produces antibodies against self proteins in nucleus. Symptoms can be fever, malaise, joint pain, muscle pain, fatigue, chest pain, hair loss, mouth ulcers, face red, rash on cheeks, that is called butterfly rash, photosensitivity, malar roche, that is on cheeks, rash on cheeks. Complications: heart, pericarditis, myocarditis, endocarditis, atherosclerosis. Lungs, pleurisy, pneumonitis, kidney, painless passage of blood or protein in urine, psychiatric disturbances, eyes, dry eye syndrome, Raynaud's phenomenon, fingers turn white or blue on cold. Investigation: blood hemoglobin decrease, WBC decrease with lymphopenia, platelet decreased. ELI cell test can be done. It is ELI cells seen in buffy coat of patients. In this picture you can see. Then anti-nuclear antibody test positive, anti-DS DNA test by ELISA or immunofluorescence positive, anti-Smith antibody test. Prevention can be lifestyle modifications, avoid sunlight, avoid activities that induce fatigue. So in this picture you can see female with the butterfly rash, that is rash present on the cheeks. Lymphoma, it is group of blood and lymph tumors that develop from lymphocytes. So two types: Hodgkin lymphoma almost 10% cases, and non-Hodgkin's lymphoma 90% cases can be seen. Clinically, enlarged lymph nodes, they are painless, fever, sweating at night, weight loss, itching, constantly feeling tired. Risk factors can be Epstein-Barr virus infection, autoimmune disease, AIDS, tobacco smoking. Investigations, lymph node biopsy, blood, bone marrow testing can be done. So in blood, bone marrow, you can see abnormal cells, that is Rein-Sternberg cells seen in lymphoma. Hope you find this session useful for your understanding and for your exams. Thank you.